Hello, everyone. Welcome to the webinar, Analyzing and Interpreting Cognitive Decline Data in the BRFSS. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentations. Throughout the program, we will be accepting questions through the questions feature accessible on the GoToWebinar panel. Our speakers for today's program are Dr. Christopher Taylor and Dr. Benjamin Olivari at the CDC Alzheimer's Disease and Healthy Aging Program. So without further delay, I'll hand the microphone to Dr. Christopher Taylor.
Thank you, Judy, and thank you everyone for joining us this afternoon. This is the second in a four-part webinar series coordinated by CDC with GSA. And because this is a second series, we encourage you to go back and view our very first webinar, which was last Friday, and you can find that webinar archived at geron.org/webinar. As Judy said, we're going to be talking more about the cognitive decline data using the Behavioral Risk Factor Surveillance System, or BRFSS. So I'm going to go through a couple background slides. Some of this was covered in our last session, but I want to make sure that everyone gets the same information. So in the United States, we estimate there are about 5.8 million adults with Alzheimer's disease or related dementia, and that number is expected to increase to 14 million adults by the year 2050. We estimate that 1 in 10 adults over the age of 65 has some form of ADRD, and that includes 1 in 3 adults over the age of 85, 2/3 of whom are women. And this is based on the 2020 Alzheimer's disease facts and figures from the Alzheimer's Association. So how do we know how many people have Alzheimer's disease? It's a hard thing to measure. You can't call someone on the phone as part of a telephone survey and say, do you have dementia? So the current estimates we have are extrapolations from community-based longitudinal studies that are then applied to a nationally representative sample. Now, this study design ensures that everyone gets a diagnostic evaluation, but we know that's not necessarily true for many older adults. And since the cause of Alzheimer's disease is unknown, future projections about the number of adults with Alzheimer's disease are based solely on demographic changes, meaning as adults live longer and there are more older adults in society, we expect the number of adults with Alzheimer's disease to grow. So since we don't ask about Alzheimer's disease in a telephone health survey, what we find very useful in public health is an alternative measure that we call subjective cognitive decline, or SCD. So this is the self-reported experience of confusion or memory loss that is happening more often or is getting worse over the past 12 months. So this is something that's self-reported by a survey respondent. So while we know that not everyone with subjective cognitive decline goes on to develop dementia, studies have shown that many do. And so this is useful because SCD can be an indicator of potential future burden and needs for things like healthcare systems, communities, and long-term services and supports that support adults with Alzheimer's disease and related dementia, as well as their caregivers. And I mentioned this on our last session. There's many important reasons why someone might want to get an early diagnosis of, an early assessment of their cognitive decline symptoms. Not everyone with symptoms of cognitive decline or symptoms of memory loss necessarily has a form of Alzheimer's disease or related dementia. In fact, in some cases, symptoms might be treatable or reversible. Studies have found that clinically, some people present with memory problems that might be related to medication interactions, vitamin deficiencies, or sometimes severe infections like profound urinary tract infections. We also know that treatment of Alzheimer's disease is most effective early in the process, We know that those diagnoses are more accurate early in the disease process, and medical histories are more accurate early on as well. An early diagnosis is important for assessing injury risk, which could be useful in reducing preventable hospitalizations later on. Additionally, an early diagnosis can be empowering because a patient can begin to participate in planning their own medical decisions, their legal decisions, financial decisions, including decisions related to long-term care, how people want to spend their years as they age. It's also important because patients can begin to understand what's going to happen as they progress through stages if they do have a form of ADRD. It also increases the possibility that they can participate in clinical trials. Often they found that early stage patients are lacking in their participation in clinical trials because people in their early stages with mild cognitive impairment often don't report these symptoms to their doctor, and so they're not diagnosed early or assessed early, and so they're not able to participate in clinical trials. Also gives a chance for a patient to garner caregiver support expectations and allow family members and other caregivers to plan for future decisions. As well as we have learned that long-term care can be delayed when these decisions are assessed early on. And so now switching now from talking about subjective cognitive decline, just briefly giving a background on the BRFSS, or the Behavioral Risk Factor Surveillance System. So this is a telephone health survey established in 1984. It's one of the premier survey systems from CDC, and it surveys adults 18 years and older, and questions are asked related to health conditions, health risk behaviors, about healthcare access and utilization, questions related to chronic health conditions and injuries, as well as preventable infectious diseases. It's been administered, as I mentioned, since 1984 in all 50 states, DC, and several US territories. And there are more than 400,000 interviews completed every year. So as part of that, as part of the BRFSS, if you joined us last week, Dr. Lisa McGuire talked about the different components of BRFSS. There's core components, there's optional modules, there's state-added questions. If you want additional information, I would encourage you to go back and listen to last week's webinar. So one of the module that I'm going to be talking about is our cognitive decline module. And that's a module that we sponsor here as part of CDC's Alzheimer's disease and healthy aging program. So this module assesses subjective cognitive decline in adults. So we're able to look at the prevalence of subjective cognitive decline and areas where subjective cognitive decline may have impacted a person's daily routine or their activities. This survey module, this 6-question module, is administered to adults 45 years of age and older. And the first question screener is a screener for subjective cognitive decline. So we never ask adults, do you have subjective cognitive decline? We ask them about, have they experienced changes in their memory or confusion that have become more frequent? And I'll go into those questions in another slide. But if they say no, we move them out of the module and they're moved on to another set of questions. As I mentioned, this is an optional module, but we've had very good success that's been administered by all 50 states, the DC and Puerto Rico for the combined years of 2015 through 2018. And our program's goal is to again have all 50 states administer the module at least once again between 2019 and 2020. So as you can see here on this map, this is just a summary of the states in their year of administration of the subjective cognitive decline module. And now I'll move into the questions. So as I mentioned, it's a 6-question module, and the very first question asks, during the past 12 months, have you experienced confusion or memory loss that's happening more often or getting worse? It's a yes/no question. As I mentioned, if they say yes to the question, they continue on with the remaining 5 questions. If they answer no, they're exited from the module by the interviewer and they move on to their next set of questions. Don't know or refused is an option, and that's less than 1% of all responses. And generally, we don't use those responses in our statistical analyses that we have done here at CDC. We do know that based on data that we've published, that about 1 in 9 adults, 45 years of age and older, do report subjective cognitive decline. And so I want to note that this is a self-report question. And as part of just some caveats here that I've noted on these slides, because this is really more of an analytic presentation, so we want to give you a little more background, things to think about analytically as you're using these questions for your statistical analyses. So one, additionally, so we ask, are these symptoms happening more often or are they getting worse? So I want you to think about what the meaning of that would be in your analyses. It's not a subjective, assessment. This is someone's self-reported assessment of their symptoms. And also asks during the past 12 months. So if someone maybe had a profound change maybe 10 years ago, but they've been stable for the last 12 months, they might not report that, but that doesn't mean that their memory is as good as it should be. It doesn't mean that their memory is as good as it was 20 years ago. So these are some of the things to think about when you interpret the questions in this module. So moving on to the second question, during the past 12 months, as a result of confusion or memory loss, how often have you given up day-to-day household activities you used to do, such as cooking, cleaning, taking medications, driving, or paying bills? And so this it's a 5-level answer of always, usually, sometimes, rarely, or never. And again, don't know or refused is an option, and that's less than 2% of responses. So generally, in our statistical analyses, what we have done is we have grouped together the always, usually, and sometimes responses into one group, and the rarely and never responses into another group. And just some notes that the question includes as a result of confusion or memory loss. So we're not asking people, have you given these up, just in general. We say as a result of confusion or memory loss, how often have you given up these activities? And additionally, as I just mentioned, it's have you given up these day-to-day activities? So not has your frequency changed? We ask, have you given up these household activities? Again, just things to think about as you're going through these questions. Moving on to the third question, assistance with day-to-day activities. So as a result of confusion or memory loss, how often do you need assistance with these day-to-day activities? Again, the same 5 responses, always, usually, or sometimes, which we group together with rarely or never. Also note that this is as a result of confusion or memory loss. And we ask about, do you need assistance with these day-to-day activities? Whereas question 2 asks about, have you given up these day-to-day activities? So it's a different interpretation. And we do know that about 35% of adults with SCD have reported that they need assistance with day-to-day activities. So about 1 in 3 adults with these symptoms. Question 4, ability to get needed help. So when you need help with these day-to-day activities, how often are you able to get the help that you need? And so one note here is this question is only asked of those who reported that they always, usually, or sometimes needed assistance in question 3. So this is a subset of respondents who said, yes, they need assistance. And so we asked them, how often are you able to get that assistance? Again, it's always, usually, sometimes, rarely, or never, grouped together in the same way. And don't know or refused responses account for less than 0.5% of all responses. So our 5th question is impaired ability to work. So again, during the past 12 months, how often has confusion or memory loss interfered with your ability to work, volunteer, or engage in social activities outside the home? Again, our same 5 questions, or same 5 responses, always, usually, sometimes, rarely, or never. Again, grouped together in the same way and with the same caveat. So we ask, due to confusion or memory loss, has this interfered with your ability? So not have you given up, has this interfered with your ability to do work, volunteer, or engage? as well as I want to remind you that this is everyone who reported subjective cognitive decline. So remember that question 4 was a subset. We're back now to all respondents who said yes, they have SCD, who are categorized as having SCD. And we do know that 1 in 3 adults with SCD do report that confusion or memory loss has interfered with their ability to work, volunteer, or engage in social activities outside the home. And the final question, question 6, have you or anyone else discussed your confusion or memory loss with a healthcare professional? This is a yes/no question, and it includes obviously the respondent, or if they know of someone in their family who has discussed these symptoms with a healthcare professional, yes or no. And we know that less than half of adults who report that they have subjective cognitive decline symptoms have discussed these symptoms with a healthcare professional. Additionally, one of the variables we create, we call functional limitations due to SCD. So this is a calculated variable that the analyst must create. It's not included in the BRFSS dataset. So someone is classified with a functional limitation if they either report that they always, usually, or sometimes have given up day-to-day household activities that we listed, including cooking, cleaning, taking medications, driving, or paying bills due to confusion or memory loss, which was question 2, or if symptoms of SCD have interfered with their ability to work, volunteer, or engage in social activities outside the home, or question 5. And so about half of all adults with SCD can be classified as having functional limitations due to SCD. So data availability, I added this slide in. It came up on our last week's call, and so I wanted to make sure. So if you're interested in these data sets, so the actual statistical data sets, you can find them online. They're publicly available at www.cdc.gov/BRFSS. On that page, if you click on the survey data and documentation, there's a lot of information there. And then the actual, if you go to the annual survey data section, there'll be a whole lot of information that you can look at. There's an overview of the survey data. There are code books that give you variable names. There's a summary data quality report, which gives you the response rates of participants. There's the weighting formula. BRFSS is weighted to the participating states, statistically weighted. And also, you can find the different BRFSS modules by the states when they administer them, as well as by the category, as well as the data files, both in SAS format and ASCII format, and in the variable layouts that you need, as well as SAS formats and different analytical tools that you might find helpful. That's all at cdc.gov/BRFSS. Additionally, we do have some items to assist you with statistical support. Here, we do have a brief, our statistical brief, that we keep updated. This is on the cognitive decline optional module. This is available at the website at the bottom, cdc.gov/aging. And if you use the menu bar on the left, you'll be able to navigate to this. It's a PDF that you can view. And there's some examples of statistical software code within that. This is a screenshot from that document. So again, it goes through all the questions that we just went through. It shows you some sample statistical code. We have both examples for Stata as well as for SAS. And so we hope you find that useful. Again, some examples here with variable values and variable names that's included for all of the questions. Additionally, there's a module summary. So you can look to see the questions that are on there, the various responses. That's also available on the BRFSS website, but we also have it here within the document at cdc.gov/aging. And just some examples here of published analyses using the cognitive decline module. So we've been able to look at the prevalence of SCD in the United States. There's been analyses done on unmet needs for assistance related to adults with SCD among community dwelling middle-aged and older adults. where we were able to pull in data from our caregiver module, which will be the topic of next week's webinar. So I invite you to join us for next week. We've done analyses looking at sexual and gender minorities using BRFSS Sexual Orientation and Gender Identity module. We've published analyses looking at the association between physical activity level and subjective cognitive decline, and that was using BRFSS physical activity core questions and chronic diseases in middle-aged adults with SCD using BRFSS's medical history core questions. And so now I will pass the baton over to Mr. Benjamin Olivari, who will be talking more about data products associated with our cognitive decline.
Thank you so much, Dr. Taylor. So I'm going to move into some of the more practical aspects of how we ourselves at CDC and some of our partners have used the data from the cognitive decline module that Dr. Taylor just went through. So one of the resources that we've created at CDC that can be found on our webpage is the Alzheimer's Disease and Healthy Aging Data Portal. The portal allows for access to national and state level CDC data, and by national, what we mean is aggregated data across multiple states over the course of multiple years. We include data on caregiving, cognitive decline, various screenings and vaccinations, as well as mental health in that portal, and some overall health question responses as well. We do update this data portal each and every year. So we're still working on uploading the most recent data, which is from the year 2019. However, we have data through the year 2018 available on the web page, and the 2019 data should be made available relatively soon. Typically, the data are released in the late summer and early fall, and we typically turn around that data and post it upline within about a half a year. So typically, it becomes available on the data portal site in early either the winter or early spring. So you can find the web page through cdc.gov/aging/aging data. Or you can navigate to the cdc.gov/aging homepage, which is the Alzheimer's Disease and Healthy Aging Program's home website. And you can navigate to the Data and Statistics menu, which is on a sidebar on the web page. And then navigate to the Alzheimer's Disease and Healthy Aging Data Portal. And I'll show you what that looks like in just a minute here. So when you navigate to that page, this is what you'll see. You'll see this web page with the data portal by location. So you can select by state, or you can select the United States as a whole. You can also, on the right side, select a specific category of interest. So if you're visiting interested in caregiving or cognitive decline, you can select one of those categories. You also have the ability to create custom reports. So if the data appear in a way that is not helpful to you, you have options to create some custom visualizations yourself. That is a little bit more complicated to do, but I encourage you to play around with that feature if you're interested. So once you select, say, the United States from that drawdown location menu bar, this is what will happen. So here I've selected the state of Georgia, and the category that auto-populates will be the overall health category. However, if you use the drawdown menu under the category section, you can go to any of these listed categories as well. So we'll navigate to the cognitive decline one. So once you navigate to the cognitive decline category, you're able to select which specific year of data you're interested in. So here you can see we have the years in which the cognitive decline module was administered in Georgia. So that would be 2015 and 2017. Or if you use the most recent feature, it'll auto-populate the data from the year that the module was administered most recently, and the 2015 to 2018 will also pull the most recent year. within that time frame. So you have several options. As you can see, it will auto-populate below with these bar graph forms. However, in the upper right-hand corner of each of those data sections, you're able to choose either those bar graphs or the table form, and the table form will actually produce the confidence intervals for you as well. So you can see that below the overall prevalence, it will also give you that 95% confidence interval. And within there, you can select by age group, you can select by several different categories, and I'll actually take you to the website itself so that you can see that. So I'm just going to do the United States, and that will aggregate data across all of the states. It does take a couple seconds, so please be patient while it loads, but it will load relatively quickly. So I'm going to do the 2015 to 2018 aggregated data. So that will pull the most recent data from each of the states that administered the module during that time frame. And as you see here, you can actually play with whether or not you want to look at, say, whether or not the respondents were male or female. And you can also play with the specific race and ethnicity of respondents. And again, as I mentioned, you can view the data in table form. You can also select by a specific age group. The two age groups that we have here that are more specifically stratified within the overall responses across everyone who responded to this module is 50 to 64 and 65 years and older. And again, just wanted to reiterate that for the cognitive decline module, all respondents are ages 45 years and older. So people ages 18 to 45 are not included in these responses. Another resource that we've developed at CDC with the Alzheimer's Association are some of these very neat graphics that display the responses to the questions that Dr. Taylor went over from the module. So you can see here, this particular one on the left side is a infographic for the United States. So this one includes all 50 states, Puerto Rico, and the District of Columbia. And it includes everyone from the survey, so that would be all persons 45 years and older who responded to the survey. And it's very easy to print out and bring to, say, meetings for people who are unfamiliar with the data. And you're also able to pull specific state level infographics as well. And those are all posted on our website at cdc.gov/aging. And you can pick and choose which specific years you're interested in as well. We did also produce several more specific infographics on race and ethnicity. So here you can see we have some on African-American respondents, Hispanic respondents, and American Indian, Alaska Native respondents. We also have several others posted on our website as well, and those include Asian and Pacific Islanders, as well as we have some by gender, and that includes male and female, as well as LGBT. And all of these infographics, the aggregated ones across the US, as well as the individual more specific infographics, are available in Hispanic language as well if people are interested. So those Spanish translations, you're able to share with specific subsets of the population, or if you have a large Hispanic population in your state or jurisdiction, those are available for you as well. We did also produce several data briefs that use the BRFSS Cognitive Decline module data. We titled these The State of Aging and Health in America, and they focus on adults ages 45 years and older. So it does include some individuals in middle age, as well as those who are older adults. So these data briefs were developed with the National Association of Chronic Disease Directors, or NICDD. We produced 4 briefs. They cover the topics of subjective cognitive decline, caregiving, coronary heart disease and stroke, chronic diseases, and cognitive decline. And all of these briefs do provide data by state, age, gender, race, and ethnicity. This is all, again, from BRFSS data. It includes data from specific modules, as well as data from the core BRFSS module. And at the end of each of these briefs, there are some specific action steps that are laid out for public health and other officials, as well as partners, to improve the health and well-being of some of these middle-aged and older adults using these data to inform your decisions. Here I'm going to focus on just 3 of these data briefs. Next week, if you're able to attend the caregiving webinar, I will also go over some of the data from the caregiving data brief. But for this one, I'm just going to focus on SCD, heart disease, and chronic diseases and SCD. So here's an example of what some of that data looks like in the data brief, and some of the ways in which we can use these data in more practical ways for readers. So here we've produced a map of the United States. This is actually using data from 2015 to 2017 on older adults with SCD who live alone. So again, that's a second stratification of those who did report cognitive decline. So all of these percentages that you're seeing here are for individuals who reported SCD and also live alone. So among those with SCD, about 30% of those live alone. And as you can see, we can break out the specific percentages based on age. So here, there are fewer people who live alone at younger ages, as opposed to those who are 65 years and older. About 12% of those individuals with SCD did live alone. The percentage of women and men who live alone with SCD are fairly comparable at 30 and 28% respectively. We do have the ability to look at these data by race and ethnicity as well, and as we can do with many of these questions that we're going over here today. The chronic conditions and cognitive decline brief looks at several different types of chronic conditions, as well as the number of chronic conditions by SCD status. So for those who are experiencing symptoms of memory loss or increased confusion, chronic disease management can be particularly complicated. So it's important that persons with 1 or more chronic conditions have those memory concerns identified and discussed with a healthcare provider, as that can help improve the care that that individual receives and help keep those persons safe. So the main takeaway from this table is that persons with SCD are also more likely to have other comorbid chronic conditions. So you can see here, regardless of age group, those persons with SCD did experience having other chronic conditions at higher rates than those who did not experience SCD. From the heart disease brief that we produced, we did also look at how subjective cognitive decline and heart disease, how the relationship coexisted. For those of you who are familiar with Alzheimer's disease and related dementias, we know that there is a relationship between heart health and brain health. And as you can see here, about 22% of persons with heart disease also reported having SCD symptoms. And we did produce these nice graphics by state. So if you're interested in one particular state or comparing your state to other states, you're able to do that within the brief. You're also able to do similar things in the data portal that I mentioned earlier. So I'm going to go over now a few ways in which the data can be used to help inform national health objectives. And one of the ways in which we've been able to do that is through Healthy People. Healthy People is a long-standing national health initiative through the Office of Disease Prevention and Health Promotion at HHS, and it also involves many federal agencies and incorporates comments from the public to inform the measures that are selected. So what Healthy People does is it provides 10-year measurable health, public health objectives and sets goals each decade and tracks whether or not those goals have been achieved or whether progress has been made towards achieving those goals. So the most recent version of Healthy People is Healthy People 2030, and that came out within the past year, and that can be found at health.gov/healthypeople. The biggest difference between the latest rendition of Healthy People 2030 versus Healthy People 2020 is that the overall number of health objectives was reduced from about 1,200 core objectives to less than 400 objectives. These objectives do include both infectious disease as well as chronic disease measures. So things like immunization rates or smoking cessation. And they lay out a way forward and help track whether or not we're improving or worsening as a nation with the specific data that we're looking at. So in Healthy People 2020, we did have two specific objectives related to Alzheimer's disease that were included, and those were to increase the proportion of older adults with a diagnosed Alzheimer's disease or another dementia, or their caregiver who are aware of that diagnosis. And then the second was to reduce the proportion of preventable hospitalizations among older adults with Alzheimer's disease or another dementia. And those two objectives have been retained for the 2030 slate of Healthy People objectives, but we did also include a third new dementias, including Alzheimer's disease or DIA objective, and that is to increase the proportion of adults aged 45 years and older with SCD who have discussed their confusion or memory loss with a healthcare professional. And I just wanted to point out the specific data sources that are being used. So for those two previous Healthy People 2020 objectives that have been carried forward into 2030, those use the CMS Medicare Current Beneficiary Survey to track whether or not persons with Alzheimer's disease are aware of their diagnosis, and the objective relating to preventing hospitalizations among those with Alzheimer's disease uses HRS, or Health and Retirement Study data, through the University of Michigan. And this new third objective actually uses data from that Cognitive Decline BRFSS module from the final question in that module that asks whether or not persons with SCD symptoms have discussed those symptoms with a healthcare professional. So the baseline data is from 2015 and 2016, and that is approximately 45% of adults who discussed their memory loss symptoms with a professional, and the goal is to increase the percentage to about 50.4% by the end of the decade. So that would be by the year 2030, increasing by about 5%. So there's several different ways you can use Healthy People, depending on whether you're working in academia, whether you're working in public health as a state and local health official. You're able to browse the specific objectives that you're interested in. As I said, there's quite a wide variety of health objectives. And I'm not going to go through all of those, but I encourage you to explore Healthy People, the webpage, to see what you're interested in. You can also compare whether your state is, meeting these national data goals, and there are several tools within the Healthy People webpage that helps look at some of the health disparities, whether that's certain disproportionately affected populations, whether that's a certain lens towards addressing these issues, such as social determinants of health or several other ways in which we can address these health objectives. And then again, we'll be updating the progress towards meeting these health objectives during the decade. So we have updates throughout the decade each and every year, but we primarily update all of these objectives at the mid-year point. So that would be 2025 and at 2030 at the end of decade for those objectives. So CDC has also produced several different what we call issue maps, and these issue maps are primarily intended to be used by public health and other partners in their public health efforts. And like I said, we have several of them, and they all accompany what we call our Healthy Brain Initiative state and local roadmap. And we have these specific issue maps. This one focuses on data and evidence for action. So it's not specific to cognitive decline in particular. However, there are some tips about how data can be collected, how it can be used to help guide public health action. And there are some state examples in terms of how those data have been used in pretty neat ways. So I encourage you to check that out. And there are, like I said, there are other issue maps that are more specific to other areas as well. So I just wanted to go over some of the overall usefulness of the cognitive decline data from the module, and Chris alluded to some of these earlier. So cognitive decline is actually one of the earliest potential indicators of dementia, although that is to say that not everyone who experiences SCD does have dementia. As Dr. Taylor mentioned, sometimes it can be a treatable form of memory loss or another comorbid condition or medication that's leading to those symptoms. But with the disease progression of Alzheimer's disease specifically and some related dementias, it's important that we identify these symptoms relatively early, even if it doesn't necessarily predict that that person will have dementia, because the earlier we're able to use interventions and help persons experiencing these symptoms plan for the future, the more likely we are to have success in treating and providing resources to those individuals and their families in terms of planning. It's also important to note that the persons who do not report subjective cognitive decline are actually quite unlikely to score poorly on objective measures of cognitive decline. So that is to say that it's actually fairly good at ruling out people who are experiencing severe memory issues. So if you say no to that initial trigger question of cognitive decline, it's fairly unlikely that you're experiencing a cognitive decline in a more objective way that would be identified with cognitive decline measurements. And the nice thing about the BRFSS is that we can combine the cognitive decline module with other questions. So whether that's persons with other chronic conditions or those other questions from the cognitive decline module itself, such as the questions related to functional impairment as a result of SCD symptoms, that can help elucidate some of these interactions between cognitive decline and whether or not that person might go on to eventually be more likely to have a more severe cognitive impairment in the future. And again, it's important that we talk about brain health, whether that's with a provider or more generally, and that we have these open conversations and we feel more comfortable talking about how our memory may have changed within the past year or several years. I did want to note some of the limitations of the cognitive decline module data. So this is an important one. BRFSS is a cross-sectional survey. So often we have questions that relate to whether a person has a formal diagnosis, whether they go on to have a formal diagnosis at a later time. But all of this data is subject to self-report, and it's just a point in time response. So we can't track whether or not those individuals eventually went on to have a formal diagnosis. However, it can still be informative about the populations at that time who report cognitive decline symptoms, even if we're unable to track those individuals and correlate those responses to a formal diagnosis. And again, subjective memory complaints do have that limited positive predictive value for future dementia, but it can still be informative, and it's important to talk about how cognitive decline relates to other comorbid conditions and other social factors, and to help in planning and policy making related to dementia and to plan for the future. And finally, the BRFSS is quite expensive to administer. So that's just something to keep in mind, that it is a very long survey. It's time consuming. We're limited in the number of questions that we're able to ask specifically about cognitive decline. And we try to keep those questions fairly brief, and that does limit the use of those questions in that sometimes we have to combine some different components of cognitive decline within one question. As you saw in that first question, there are actually several different components about confusion and memory loss symptoms, as well as the time in which those occurred. So those are just some of the complications involved. We do have a couple more of these GSA BRFSS webinar series that I wanted to mention. Next week, there will be one on caregiving, and that will be led by Dr. Bolden from Appalachian State, who works with us at CDC as well. And I'll be providing some more of these kind of practical implications of the caregiving data. And then on Friday, March 5th, the Alzheimer's Association with Matthew Baumgart and John Sheen will be presenting about how these BRFSS data can be used to inform and impact the public health community. And if you're interested, we do send out newsletters, usually once or twice a month, with updates. So sometimes that involves new infographics, sometimes that's new studies that we've used with BRFSS data or other data. And I encourage you to sign up if you're interested in getting the latest information that we are able to publish. And the link for our webpage is here as well. And we have other resources that are related to Alzheimer's disease, as well as caregiving, not specifically just BRFSS data. So I encourage you to visit. And feel free to shoot myself or Dr. Taylor emails if you have any specific questions that we aren't able to answer in the Q&A. And with that, I think we'll probably open it up for questions.
Thank you very much, Ben. We have some questions here in the chat. I'll go ahead and go through them. So the first one is, what exactly is meant by being an optional module? Does everyone age 45 plus whose state opts in take this module? So an optional module means that the state can choose to administer the module that year or not to administer the module that year. BRFSS has different components, so there are core questions that are included, and if you administer the BRFSS, you have to include those core questions. This module is optional, so states, when they have time, when they feel they have the need, can choose to administer it one year and not administer it the next. So that's what we mean by optional. Obviously, when someone responds to the survey, they're free to answer whatever questions they like to answer. They're free to refuse a question that makes them uncomfortable, and they can move on, and they'll move on with the interviewer. So Next question is, given that ADRD is a public health crisis, why is the SCD module voluntary and not mandatory for states? Sort of what I just mentioned. So BRFSS is a partnership between CDC and the states that administer BRFSS. So the BRFSS, each state has a BRFSS coordinator, and they are our partners with CDC in that state. And so states have a lot of freedom to decide what they feel the needs are for their own particular state, what they have time for, what they feel their population will respond to. And so we allow the state BRFSS coordinators to really know what is right for their state. And I also would encourage you, if you're looking for additional state-specific data that we might not have, to reach out to your own state BRFSS coordinator. They're great partners of CDC, and they'll be a wealth of knowledge if you have additional questions or assistance. Wanted to mention that as well. So next one is, do you have published analyses for SCD by state and county, specifically California and Santa Clara? So as Ben mentioned, we do have some state-specific infographics. You can look at state-specific data in the data portal. We don't have county level data. BRFSS doesn't release county level data in the public data sets. But when we've looked at STD, the prevalence in California, so you can check out all of our infographics, and you can check out the data portal for California specific STD data. Next question. Comment on how this is viewed in the big picture, given the long length of dementia. This leans towards capturing information on the early signs and symptoms, which is needed. Just wondering how it plays out. For example, people at later stages are not likely to be answering the survey. Are there proxies doing so, or are they not included in the data here? Also a great question. So BRFSS does not use proxy respondents. So anyone who responds to BRFSS is responding for themselves, or occasionally, they'll be answering questions about their family or their household, but mostly about themselves, their personal health conditions, things like that. So proxies are not included. And so also a reminder, BRFSS is only a survey of community living older adults. So when we're talking about cognitive decline, we do know that there are a lot of older adults who are living in assisted living or other forms of long-term care facility. They are not included in the survey. Only community dwelling adults, and also the interviewers. I mentioned this on the last webinar session. Our interviewers for BRFSS are well trained, so if they feel someone is not providing reliable data, they will end the interview. We want to make sure that all of the data is reliable. If we feel someone is maybe having some cognitive issues or some other kind of issues where the interviewer believes they're not providing reliable data, we won't continue collecting the data from that respondent. Additionally, okay, so I know BRFSS is done via phone. In the future, will there be more options for a larger number of participants? Text, phone, email, online, etc. I will say, so yes, BRFSS is a telephone survey. The BRFSS is, we're in the same division of them. They are incredible colleagues, and the work they do to turn this incredible survey into usable data is a Herculean task that they do every year throughout the year. And they are constantly innovating. They are looking at new ways to make people engaged on the phones, because if you can get someone while you're doing a survey to stay on the phone, you can get them to answer the questions. So innovate new ways to get people to stay on the phone, go further to answer more questions as part of the survey, the best ways to recruit people, whether it's through letters, whether it's through phone calls. They are doing all of that, constantly trying to innovate to make sure that BRFSS remains such an important health survey. And for a lot of states, it's really their only source of health data like this. And so a lot of the individual states really depend on the data that are collected from BRFSS. So can prevalence data be gotten for individuals in 10 age increments, such as prevalence in individuals 65 to 74, 75 to 84, 85 plus? If you download the data set, there's a lot of options for different age groups. We'll say BRFSS in the publicly released data sets, the age is capped at 80 years, and that's to prevent inadvertent identification of someone who may be very long-lived in a particular community. And so anyone, so for example, if someone is 85, 86, 91, 97, they're all coded as being in the 80 or above age group. So you can't go above age 80 when looking at the groups. Ben, I'm going to pass this question to you. Why are data from Pennsylvania unavailable in the data briefs?
Sure. So I did want to point out that the data briefs that I showed on the screen, those are actually from 2015 to 2017 specifically. We do have more recent data from 2018 also posted. However, that didn't make it into the data brief that I showed you. But that being said, all of the data is based on the years in which states administered those surveys. So from the years 2015 to 2017, the state of Pennsylvania didn't administer the module since it is an optional module. So that's the reason that Pennsylvania is that one state that's missing during those years. However, there is state level data available for Pennsylvania in the year 2018. You would just have to visit one of the other web pages that we talked about to view that specific data.
Thank you. So the next question, and we only have a few minutes left. Can researchers administer this module for their own projects? Do we need permission? You do not need permission if you feel these questions could be helpful. These are all part of public domain data. So if you find one of the questions could be useful and you could administer it in a scientifically feasible way, then you are more welcome to do that. Next question, I'm interested in learning if you collect data about wandering. We do not collect data as part of in BRFSS about wandering. There may be other health surveys that do, but we do not in BRFSS. So are there options about shortening the BRFSS in the future to shorten administration time? How did you select subjects for the survey? So as I mentioned, BRFSS is constantly looking at ways to innovate. We're actually in our program in a process now of looking at our questions as we do every few years to make sure that the questions are still scientifically relevant, to make sure that we're asking the best questions that we can, to make sure that the time that we have with the respondents on the line, which is very valuable time for them, we want to make sure we're collecting the best data possible. And so we do revisit those questions. In terms of how do we select subjects for the survey, so BRFSS is a random digit dial survey. And so as part of BRFSS's design, they determine how the phone numbers are collected, and then their trained interviewers are all part of that. And I would encourage you to look up the methods on BRFSS website at cdc.gov/BRFSS. Can we administer the questions in Qualtrics or another online website format? If you're talking about administering the questions for your own purposes, you can do that in any way you want. The questions, as I mentioned, are available on our website as part of BRFSS's data dictionary, as well as in our cognitive decline data briefs that Ben had mentioned. Just a few more minutes left. So how does SCD compare to MCI, which is mild cognitive impairment? Is there a difference between these two indicators? So mild cognitive impairment is something that's really more of a assessment given by like a healthcare professional, whereas subjective cognitive decline is in the name, it's subjective. So this is what someone feels that they have had, that their memory or their confusion has become more frequent or worsened over the past year. So that's really the difference. One is sort of an assessment and one is really self-report. And I think we are just about at time. I wanted to again say thank you all so much for taking the time to join us. We hope you'll join us next week for our talk on caregiving data, and check us out on jaron.org/webinars for last week's and then soon this week's webinar if you want to be able to look at it again as well as download the materials. We appreciate your time.
Yes, I am so very sorry we've run out of time. Thank you, Dr. Christopher Taylor and Dr. Benjamin Olivari. This has been quite an informative hour together. And thank you all our attendees. This is the end of the program.